Hi again. In this discussion, we'll be talking about your hyperthyroidism. So hyperthyroidism, our problem is that there is an excess of your thyroid hormones. So we're talking here about an excess of your T3 and your T4. Now, what are the types, etiology, and risk factors of your hyperthyroidism? One is your Graves' disease. Class, your Graves' disease is the most common cause of your hyperthyroidism. It is characterized by toxic diffuse goiter. Okay, it's an autoimmune disorder which leads to the increase in size and overproduction of hormones from your thyroid gland. Okay, it is more common in women compared to men. And they are usually triggered by emotional shock, stress, or even infection. Now, what are the principal hallmarks of this disease? So there are three. One is your hyperthyroidism. Second is your goiter or the enlargement of your thyroid gland. And then you have your exophthalmos or the bulging of your eyeballs. Then etiology. So class, your hyperthyroidism could be familial or autoimmune. Then it could be caused by the overfunctioning of the gland because of overstimulation. It could be by too much increase of your thyroid stimulating hormone. It could also be caused by adenoma of the gland. So class, whenever there is presence of cancerous growth in the thyroid, they usually manifest as hyperthyroidism. Then you have your overtreatment of myxedema. So class, management of hypothyroidism and myxedema coma, if not managed well, could also lead to hyperthyroidism. As mentioned earlier, treatment for hyperthyroidism can lead to hypothyroidism and vice versa. So, treatment for hypothyroidism could lead to hyperthyroidism. So, pathophysiology. So, the increase of your thyroid hormones would have widespread effect, systemic effect, just like the decrease of your thyroid hormones. So, there will be hypermetabolism. Hence, there will be an increased sympathetic nervous system activity. So remember, your SYMPA is your fight or flight response. So class, if your patient has hyperthyroidism, we are expecting a patient that would have an increase in the heart rate, increase in the basal metabolic rate, and increase in the sympathetic innervation. Now, hyperthyroidism can be caused by thyroid adenoma. So class, in this case, there is hyperfunctioning of the thyroid. There is also an increase in size, so that is considered to be your goiter. Then, you have your toxic multinodular goiter. So, class, it is a multiple thyroid nodules characterized by enlarged thyroid tissues or benign tumors. Okay, there is overproduction, which is milder than that of your Graves' disease, but still there's overproduction. Then generally seen in people over 50-year-old, okay, with long-standing problems. Then you have your exogenous hyperthyroidism. Class, when I say exogenous hyperthyroidism, this is caused by the excessive use of your thyroid replacement hormones. In other words, exogenous, exo, outside the body. So this is overdosage of your medications that is being taken by the patient. Then assessment findings for a patient with hyperthyroidism. Class, they would have heat intolerance. Okay, that is the hallmark of your hyperthyroidism. There is an increase of your body temperature. There is warm, moist skin. Your patient would have ravenous appetite. They will be eating a lot. However, they will have weight loss. Okay, because of the increased hypermetabolic or the increase, of your basal metabolic rate or hypermetabolic rate. So you have your muscle fatigue. The patient feels to be tired because of too much activity. There could be muscle wasting because they are overly engaged. Their muscles are too contracted and overworking. Then your patient would have tachycardia. Tachycardia here, class, could be severe in such a way that if not managed properly, your patient may have acute coronary syndrome and then later on myocardial infarction. Then we have palpitations. Okay, it's too high. Then you have increase of blood pressure with wide pulse pressure. So recall that your pulse pressure is the difference between your systolic and diastolic. So your patient maybe would have 190 over 70 for that matter. Okay, or maybe has high as 200 over 100. So class, usually you can notice that the pulse pressure would be between 30 to 40. But in this case, class, there is a very high systolic in relation to the diastolic. There will be angina, chest pain, okay, because the heart is pumping fast, it is requiring a lot of oxygen. Then there will be dyspnea, difficulty of breathing. The patient may also manifest with nervousness and then anxiety. They tend to become restless also. Plus, their attention span is decreased. Okay, they're restless, I mean. They could not just focus. There is also emotional lability. And there could be increased libido on the part of your patient. Then, decreased fertility. There could be altered menses if we are talking about post-pubertal clients. There will be an increase of bowel movement. So if you look at this class, although there is an increase of sympathetic innervation, there's also increase of bowel movement because your T3 and T4 would trigger the bowel movement to be increased. There will be photophobia and even fine tremors. And then classic is your exophthalmos. Now, diagnostic tests. T3, T4, and TSH are expected to be decreased. I mean increase. Again, T3, T4, and TSH are expected to be increased. Your thyroid scan class will be able to show if there is an enlargement or there is an increase in the vasculature of your thyroid gland. Then, you have your ultrasound and then ECG. We are doing ECG because of too much stress to the heart. It could lead to arrhythmias. Okay, it could lead to supraventricular tachycardia. Later on, you have your acute coronary problems, and then later on, myocardial infarction. Then complications. As I have mentioned, heart disease is a common complication. So class, your patient may be able to manifest with thyroid storm. So class, in hypothyroidism, if we have myxedema coma in hypothyroidism, in your hyperthyroidism class, there will be thyroid storm. So your thyroid storm is characterized by fatal acute episode of your thyroid hyperactivity. So your patient would have high fever. Your patient would have severe tachycardia. There could be delirium, dehydration, extreme irritability, and this could be precipitated by stress. Okay? So look at this, all are up. And then instead of confusion or going down neurofunctioning, your patient is manifesting with delirium, which could be an overstimulation of neurologic activity. Guys, look at this illustration. This illustrates how your patient with hyperthyroidism would look like. Intolerance to heat, fine straight hairs, okay, the bulging eyes, you have your facial flushing, it would just usually appear red. Enlarged thyroid, tachycardia, increased systolic BP, enlargement of the breast, weight loss, muscle wasting, localized edema. Then there could be clubbing of the fingers, tremors, increased diarrhea, and then menstrual changes. So what is our management class? We give your anti-thyroid medications. Your anti-thyroid medications will be your propylthiouracil, so your PTU, and then you have your methimazole, common brand for which is tapazole. Then you have your iodine therapy. Okay, think iodine. We mentioned earlier that iodine is needed by the thyroid to produce your T3 and T4. But here comes a patient with hyperthyroidism, and we are saying that the patient would be managed by iodine therapy. What do you think will happen? Diba class, we mentioned that iodine is needed for the thyroid to produce your T3 and T4. So why would I be giving iodine? Okay, so class, you have your SSKI and your Lugol's solution. So class, your SSKI is your potassium iodide. Okay, it's a potassium iodide. And the effect of your iodine, the strong solutions of your iodine. So you have your SSKI and Lugol solution. Its effect is referred to as your Wolff-Chaikoff effect. So class, in your Wolff-Chaikoff effect, it is an autoregulatory phenomenon wherein a large amount of the iodine would acutely inhibit or stop the thyroid hormone synthesis to form the thyroid hormone synthesis regardless of the level of the thyroid stimulating hormone. Hey class, it's wise for you to know that the follicular cells I mean, in the thyroid gland is the one that is producing your thyroid hormones. So in your Wolff-Chaikoff effect class, okay, the Wolff-Chaikoff effect would stop the follicular cells in the thyroid gland to produce your thyroid hormone, even if your thyroid stimulating hormone from the anterior pituitary gland is still increased. Okay, so again, the iodine decreasing the functioning of your thyroid is referred to as your Wolff-Chaikoff effect. Then you have your radioiodine therapy, iodine 131. So earlier we said that radioactive substances could possibly cause hypothyroidism. So this time you are using it to manage your hyperthyroidism. Then for the diet, it is recommended for these patients to have high caloric, high protein diet. So 4,000 to 5,000 kcal with high protein levels. Because why? Okay, these patients are moving a lot. They tend to have hyperactivity, so they need energy for recovery. And then for your thyroidectomy, it could be a total or subtotal procedure. Okay, so kindly differentiate or try to see what is the difference on a total and subtotal thyroidectomy. Post-operative, you'll be concerned about the comfort measures because operation is on the neck. Okay, class, usually your patient might manifest with pain also. The patient is placed on semi-Fowler's position, and then the neck and the head is supported with pillows and sandbags. We always assess the dressing for signs of bleeding, and then vital signs is continuously monitored. So class, because your patient's thyroid might already be removed, do not be too complacent on the part of your patient. The removal of your thyroid, okay, especially during surgery, it may be possible that the thyroid was manipulated in such a way that there was a surge of your T3 and T4. So class, you need to closely monitor your patient after surgery for both hyperthyroidism and hypothyroidism. Okay, there may be a thyroid storm secondary to the increased release of your thyroid hormones, okay, intraoperatively. But of course, in the longer run, we expect for your patient to have hypothyroidism. So the hypothyroidism is of course related to the removal of your thyroid. Okay? Then, we watch out for respiratory distress. Respiratory distress could be caused by hemorrhage or edema or even laryngeal spasm. So the hemorrhage or edema and the laryngeal spasm is related to the instrumentation on the site during surgery. Then we also assess for the nerve damage post-op, meaning once our patient is already awake, we need to assess their ability to speak, note tone and quality of voice because nerve damage is getting more common in your thyroidectomy. Then assess for tetany, so tingling of toes, fingers, and lips, and then twitches. And assess for Vostek and Trousseau sign. Your Vostek and Trousseau sign are signs of hypocalcemia. How come that a patient post-operatively after a thyroidectomy would have signs of hypocalcemia? What hormones of the body regulates the functioning of your or regulates the amount of your calcium? And what is the relationship of these hormones when it comes to your thyroid surgery? Okay, you try to connect the dots on that. Then the possible nursing diagnosis for this patient would include altered nutrition, less than body requirements, activity intolerance, high risk for injury, altered cardiac output. There could be a decreased cardiac output because even if the heart is pumping fast, okay, the pumping of the too fast pumping will not be able to allow for cardiac filling. Okay, so meaning there is inadequate blood that goes towards the system. Altered body temperature, and there could be ineffective coping and then deficient knowledge. So in a thyroid storm, our management, just like your myxedema coma, our priority will be the airway of your patient. Cooling blankets are given for this patient. They may be too hot. Then you have your antipyretics. They will have fever. And then ice packs may be necessary. Then class for dehydration, if ever there is dehydration in thyroid storm, plain NSS is the surgery, is the fluid of choice, I mean. Again, for dehydration, plain NSS is the fluid of choice. Then, we give the large dose of your propylthiouracil in your thyroid storm. So that could be 300 to 900 milligrams OD. We also give your methimazole up to 60 milligrams. And then we give your SSKI, the strong solution of your potassium iodide, 2 grams IV OD as prescribed. Okay, your beta blockers, 1 to 3 milligrams low IV could also be given. Your adrenal corticosteroids, such as your hydrocortisone, 100 to 150 milligrams class, is given to prevent Addisonian crisis. So, Addisonian crisis or Addison's disease later on class will be discussed once we touch your adrenal gland functioning. Okay, but just remember, to prevent your Addisonian crisis in a patient with thyroid storm, we administer your corticosteroid, such as your hydrocortisone. Then, if your patient is having signs of your thyroid storm, it is not wise for us to palpate the thyroid gland. Palpation of the thyroid gland would stimulate the production of hormones, which in turn would increase the manifestation of your thyroid storm. You don't want that to happen. Then nursing diagnosis still: altered nutrition, ineffective coping, low self-esteem, altered body temperature, usually up, cardiac output problems, high risk for injury due to hyperactivity but having tremors, knowledge deficit which may be due to inability to concentrate, and then activity intolerance class. Okay, activity intolerance is because of the rapid use of the energy of the body. So this is your exophthalmos, the bulging of your eyeballs, classic to hyperthyroidism, especially your Graves' disease. That will be all for your hyperthyroidism. On the succeeding discussion, we'll be talking about disorders of the adrenal gland. Thank you for your attention.